good afternoon, or good morning, or good evening, depending on where you are at this moment. A warm welcome to everybody to this first GloVANet-WoCoVA Meet the Expert session. My name is Tom van Bokstel, President of WoCoVA, and it's my great pleasure to welcome you all to this event. This is a follow-up to the WoCoVA Live event from last June, where we had more than 5,000 participants from 87 countries worldwide. All recorded sessions from that event are still available on the GloVANet website, www.glovanet.com. For this session, we have more than 1,400 people attending, which shows that there is a strong need for latest information on many topics related to vascular access. Based on all your suggestions, the scientific committee chose 8 topics from the 4 sessions towards the 6th WoCoVA in Athens in Greece, beginning of next year. For 2 topics for today, the 2 topics for today sessions are on catheter occlusion and thrombosis. We are happy that we have vascular access specialists to share their experience on the topic and 2 vascular access experts as a host to introduce the speakers and to lead the discussion on each topic. Of course, we want you to actively participate. On the right side of your screen, in the panel Join the Conversation, you can enter your question in English. And if you like a question, click on the thumbs up. The more clicks, the more likely it will be that your question will be answered next. Good. Next to the expert speakers, I am pleased to introduce our host for today. One is Margriet Stas, and the other one is Mauro Pieterhuti. Next to our Professor Stas is a well-known surgeon at Leuven University in Belgium. She's still struggling with her audio, I think. She has been interested in vascular access for her whole career. And next to research and many publications, she guided many clinicians to a high level of expertise. She's also a member of the WoCoVA Scientific Committee. The second host is Professor Mauro Pieterhuti. He is well known all over the globe for his expertise, research, publications, education, critical notes, but also helping others in improving vascular access skills and knowledge. I think I do not exaggerate if I say that Mauro is the driving force in bringing Italy to the forefront of vascular access innovations and expertise. Mauro is also the chairperson of the WoCoVA Scientific Committee. Of course, a special thanks goes to all our sponsors for their generous support of this event, thus allowing you to participate without any registration cost. To start with the program, I want to ask Margriet to host the first part of this Meet the Expert session and take over from here. I wish you an interesting educational session. And Margriet, if it's possible that you can take over from here and introduce our first speaker, Christian Dupont. Margriet.
Do you hear me now?
Yes.
Okay.
Yes. Just go ahead.
Thank you. So, sorry for the delay, but I'm very proud to present Christian Dupont and our first speaker of the day. Okay. Christian Dupont is already well known in the vascular access world in France and abroad. As a nurse, he worked already for 19 years at the famous Cochin Hospital in Paris in the Department of Pulmonary Diseases. He holds now the grade of nurse coordinator. In January 2019, he became the president-elect of the GFAF, the French group of vascular access specialists. Together with Dr. Irene Kriegel from the Curie Institute in Paris, he published in 2012 a book entitled A Practical Guide on Implantable Vascular Access Ports, a synthesis, in fact, of the French experience. And the second edition, with a chapter from the Swiss and Belgian colleagues, came in the fall of 2019. Today, Mr. Christian Dupont will share with us his experience on prevention and treatment of intravascular catheter obstructions. Christian, the screen is yours. Hoort u iets toch wel? Ik hoor niks meer.
Christian is muted, should be unmuted.
Oh, do you hear me?
Okay,
Yes.
now we hear you.
Yeah, sorry. Thank you, Marguerite, for this kind introduction. As you read it, I would like to talk about the practical approach to this common problem. I have no disclosure. Oh, I have a problem with my. I have no disclosure, and it all starts with a malfunctioning catheter. What is a malfunction? It can be defined as a constant or intermittent, partial or total, problem of resistance with injection, associated or not with impossible or poor blood aspiration. It's useful to define the malfunction because sometimes colleagues don't understand the problem. Here, for example, a nurse felt a strong resistance while injecting and couldn't withdraw blood. And she still used the catheter until it was totally blocked. She never tried to solve the problem because she never see the problem. Most of the time, the catheter are blocked with blood clot. This problem can be prevented. And my main message here is flush and lock properly after each use, and flush between the administration of two different products and after each blood sampling. Oh. Before going on, I'd like to underline that using the term thrombotic occlusion of a lumen or catheter thrombosis, widely used in the USA, are inappropriate. Indeed, a thrombus is something that occurs exclusively in a blood vessel. But this is not my purpose, but Sergio's purpose today. Here, you can see a blood clot. Beautiful picture, not mine. Inside the catheter, the blood clot's shape, its size, its exact location are not known. That's why sometimes it's so difficult to recover catheter patency, and sometimes we must replace it. That is never without risk. So prevention is really important to prevent blood clots, drug deposits or precipitates, flush, rinse, and lock the device with normal saline. It's effective and safe. Don't use heparin. flushing using a push-post technique is the most efficient to remove intraluminal residues, as you can see here. But be careful, it's not necessary to apply a strong force to generate a strong pressure with the syringe. But that is what happens. This is the location of a catheter tip. When you flush with a high force, you can see the tip is constantly moving and the tip can be displaced in a wrong location. So remember that every fall you experience the gentle, soft push-post technique efficiency when you sweep the leaves in your garden. Watch, this is a push-post technique to remove the leaves. It's more efficient than the first technique. So keep your eyes wide open. That's enough. A positive or neutral displacement needle-free connector prevents blood aspiration and IV line. However, it doesn't prevent blood aspiration due to the arm's movements. Tip of a peak line or tip of a midline are constantly polluted by the blood aspiration. You can't prevent this aspiration generated by the movements of your arms. We all know that the non-coring needles are required for puncturing a septum membrane in order not to damage it. But the importance bevel and the way it is oriented inside the port chamber are underestimated. The bevel should be oriented like this in the opposite direction of the catheter connection with the port in order to increase flushing efficiency. Keep in mind that it's very hard, very difficult to clean a port because of its corners. To prevent the formation of a blood clot here, when you remove the needle from the port septum, is it necessary to withdraw as you inject the saline? This is the positive pressure technique for which special needles were developed. You can see here the mechanism of the device can help withdraw the needle as you inject. To prevent drug precipitates, collaboration with chemists is highly recommended. You can see here furosemide and glucose, and you can hear the results in the line. And in daily practice, what is recommended? This is a sum up of guidelines. It will be available very soon on WoCoVA website. Guidelines without explanations and audits are nothing. What does that? Who does that? Who does that? An infusion team, of course. Let's now examine the malfunctions that we can face at the bedside. The catheter is totally blocked. What can I do? Because it's impossible to answer those questions when you are faced with a problem. Documentation and discussion with colleagues and patients are key. Keep it simple and consider simple causes like kinking, malpositioning, and malfunction of the device. If the catheter is totally blocked only when the arm is alongside patient's body, and if the catheter is inserted in the subclavian vein, this is a typical pinch-off problem. Catheter pinch-off can lead to a catheter breaking. When you can't aspirate blood or inject, think about the length and the insertion angle of the non-coring needle, and watch out for non-coring needle displacement. That's why it's very important to have an efficient dressing and securement. To avoid wasting time, when you face this, insert a new non-coring needle primed with the thrombolytic. If the problem remains unsolved, you have 3 options to try to reduce the tension between the obstructing material and the surface on which it's attached. To do so, you should use chemistry and pressure. Guide wire use is not recommended. Overpressure, forced injection is controversial. It's possible and it's efficient. It is safe with a power peak. But what about the power part? What about the clot in the bloodstream of a patient? Fortunately, in most cases, the pressure applied by actively pushing at the plunger of a 2 milliliters syringe doesn't exceed 300 psi. No more, remember, no more than 325 psi should be applied in a peak. However, we should be careful. A message can be interpreted in various ways. And even if you write guidelines with precautions, it still be difficult. In this picture, you can see the nurse broke the catheter because she wanted to unblock it by applying a high force, a strong force, on the plunger of a 10 milliliter syringe. So you have to be careful. This is an evidence-based pop technique procedure. It's a little bit different from the technique described by Stewart in 2001, and it's safe. Popping will release the clot only if adhesion is weak. In practice, effectiveness and use are limited because to clean the lumen, to totally clean the lumen, you have to inject a thrombolytic solution at the end of the maneuver. What if mechanical maneuvers don't work? Let's look at chemical solutions. Different products are used to treat different problems. The available chemical solutions are very well summed up in the Canadian Vascular Access Association guidelines. Very great work from Canada. And remember, in any case of occlusion, infuse first urokinase, as colleagues from Leuven says. But before using chemical solutions, practical consideration about the priming volume, about the recovery of the injected solution or its effect in the device or in the bloodstream must be addressed, because infusion is not a coin toss. In a few words, to prevent problem, ask a chemist for advice before doing anything and flush the catheters. And in daily practice, what can we do? The chemical treatment should always begin with a thrombolytic injection. Alteplase properties are altered by glucose. If resistance, use a three-way tap method to inject the thrombolytic solution. It's safer. However, a few questions remain. The three-way tap technique to inject the thrombolytic solution is safe and efficient when the catheter is blocked. When the catheter is not totally occluded, but you can't recover full patency with thrombolytic, get an X-ray or ultrasound. X-rays and ultrasounds are also very useful to identify a problem like this when a patient, for example, feel strange sensation or pain. Here, the patient said to me, I feel like a flux in my hair. It's not very normal. With an X-ray, you can see a non-coring needle tip malposition. You can see catheter tip malposition. Here, the catheter is too long. You can see a tip suctioning the vein wall. You can see the tip here is in the minor vessel and here is in the jugular vein. You can see a kinking of the extravascular tract. You can see a loop of the extravascular tract, or a loop of the intravascular tract, or you can see a fibroblastic sleeve. For this problem, ultrasound is very useful, as described in this paper, and this drawing explains the reason why the contrast media flows back when you inject. And you can see here the sleeve and another picture of the sleeves, and this is the wet sock effect. The sleeve is attached to the skin. A malfunctioning can also be caused by a problem with the integrated valve of the catheters. A problem catheter malfunctioning can be caused by venous thrombosis around the tip of the catheters, but Sergio will talk about this in a few minutes. Okay. Conclusion. Conclusion. To sum up, the best action against catheter occlusion is prevention. It's clear. And having an infusion therapy team is key in order to ensure local and prospective follow-up, feedback and information, team management, research that are a key for this subject. Infusion therapy is a bigger group than an IV therapy, in my opinion. The end.
Great. I suppose you have some questions first before I get to the audience. Oh.
The macro is closed.
Yeah. Gerrit, can you switch it on?
Yes.
Yeah. Okay.
I think
So maybe
that
Margaret is ready, right?
Yes.
There are already people who ask questions before the beginning of the presentation, and I think that some of them are very consequent. So is it possible to have a look at that?
Well, yeah, I think one of the questions that is very focusing on this presentation is whether saline, heparin, or citrate 4% is used in the catheters. This is also for the extension lines.
Yes.
So I think this is a good issue to discuss to prevent occlusion.
Yes. So Christian, you have an answer for that?
Yes, we use this concentration of urokinase. It's 10,000 units in a milliliter.
No, I think we are talking about prevention.
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 Yeah.
I'm glad that you did not mention heparin. Because we don't use heparin. So please comment
we
on
never
that.
use heparin to prevent catheter occlusion. We use only saline, normal saline.
The same here in Italy, in most hospitals. Sergio has a special scientific experience in publication about this matter. Sergio, would you tell us the truth that you don't need to use heparin in non-dialysis catheter? You have been published about that, right?
Well, thank you very much for addressing me. That question is a topic that I love very much, as you know. And the fact is that heparin has more risks than advantages, in the sense that there are several aspects that contraindicate the use of heparin: the possibility of mistakes, of dosing errors, the fact that half-life of heparin is very short, the fact that there is a spilling, even if the catheter is not even used, of the majority, at least 25% of the dose of heparin is going to spill, even if there is not pressure in the bloodstream. And moreover, the most important thing, and there are a lot of studies, Christian showed maybe the most important one, because it's a randomized clinical trial from the group of Leuven, the group of Margaret and Liv Goossens, in which there is no evidence of advantages of using heparin. Opposite, we have a lot of disadvantages. That's why the normal saline is preferred today, or in many areas of the world. In many areas, there's still a constant use of heparin that is a nuisance today. I think the most important thing someone asked is that we can use citrate 4%. Well, there is not clear evidence of the advantage of citrate 4%, maybe because the concentration is too low, and to have a good benefit from citrate in terms of prevention of the occlusion, we should probably use higher concentrations that can be risky. There are other substances or other pharmaceutical compounds that we could test in the future for special situations. Today, the most cost-effective solution is normal saline.
Yeah.
Yes, we had a.
Yes, yours.
We had a very bad experience with heparin allergy in a patient, and we abandoned it for every kind of catheters.
Yeah, that is true. Also for dialysis catheter, as a matter of fact, many centers, many dialysis centers in Italy and in Europe use a citrate and not more heparin. Both citrate and heparin are good in terms of prevention of obstruction, but citrate is nevertheless less dangerous than heparin.
Mm-hmm. And if I may introduce, if you look at occlusion prevention, then I think normal saline is preferable. But what about preventing biofilm and other solutions to prevent biofilm and also occlusion? Is there anything, maybe Marguerite, that you have an answer to that? Because it's not asked.
We started following the Dutch colleagues from Nijmegen to use for the patient with needing parenteral nutrition with very low fat, very high fat concentrations and risk for precipitate, to lock this catheter with Toralock.
Mm-hmm.
And as also told 2 years ago in Paris by the authors of this research program, that it was also, despite the price of the substance, really saving money because of less lower incidence of infection and occlusion.
Okay.
Yes, I think it will be important to diversify the effect on prevention of occlusion and the effect of a prevention of infection.
Mm-hmm.
There are, as we know, only 3 or 4 substances which are effective in preventing biofilm or destructing biofilm with a different level of evidence. And these are taurolidine, high concentration citrate, and EDTA, tetrasodium EDTA. The evidence is different between the 3, but they act against biofilm. But I think this is another story, because the prevention of infection in terms of cost effectiveness with such solutions will always be on a specific population, as the population that Margaret said, the home parenteral nutrition patient, which is a very big problem of infection. On the other hand, the occlusion of any catheter, peripheral, central, is an everyday problem. And I think that I would like to hear Christian's opinion about something that we often feel, the fact that many complications related to the catheter, such as infection, thrombosis, or dislodgement, are mainly based on the practice of insertion, while occlusion is exclusively a problem of management. Do you think it's true? Because my feeling is that it's the only real big complication of catheters which could be theoretically completely prevented with proper management, with the prevention method you told us.
And one remark, maybe if the catheter is really too short or too long, that's still linked, that can cause malfunction as well, but that's the exception.
And the caliber. What do you think, Christian? Do you think that we can have a target in zero occlusion in the future?
It's very difficult to have a target zero. It depends on the population. For example, you have the risk is greater with a patient that who cough a lot, because in my unit we treat a lot of cystic fibrosis patients or bronchiectasis patients. They cough a lot. It's not the same problem in for example, oncology or hematology, or when you cough, the blood come up in the catheter and it can displace the tip of the catheter or blocked with a clot the lumen of the catheter. So I think management is key to prevent occlusion, but the risk is higher in some is higher in some population.
If I may,
very good point.
Yeah, but if I may add one thing, you know, and that's also a question here, that is flushing a small bore catheter, for instance, the 1.2 French. What are pros and cons if you look at those types of catheters, and that's particularly in pediatrics, of course? Is there a difference?
I can't answer. I don't work in pediatric. I let Mauro or
well, yeah, I can give a very incomplete answer. It mostly depends on the material of the device and what device we are talking about. For instance, in neonates, we both insert central venous catheter, which are small bore, very soft, very delicate, very fragile, typically in the small superficial veins of the arm. This is the central line that we call epicutaneous-cava catheter. But on the other hand, we also put in this neonates central inserted catheters, which are power injectable, 3 French or new generation polyurethane. They are short, they go directly in the brachiocephalic with ultrasound, and they, of course, are less prone to occlusion because of the caliber, but also because of the material. Because you have a very good material, you can flush more freely and with less risk. This is a point that you made. It's still controversial. But we are running a very big hospital in which all the external catheters are power injectable. And since we are using power injectable, you use the force pressure with a small syringe. We never had any major problem. I'm talking about external catheters, not ports. And we have reduced the number of fibrinolytic interventions.
Mm-hmm, mm-hmm. And I do see a question here because I think it's very important, and particularly, well, you can see Marguerite, but this question is actually liked by several people. Is it necessary to withdraw blood from a PICC line in the home care situation, or perhaps flushing is enough to check the line for accessibility? You know, are there specific reasons? Can I
have a very strong opinion about this. So after Margaret, I will tell my opinion.
No, it seems not really necessary to do it, but I think that if you can show that there is a blood with possibility to withdraw blood, you will be sure that the catheter is still in the bloodstream and there is no movement, because PICC catheters can also move inside the blood vessel and maybe end into a position where it's not really functional anymore. So I think it's better to try to aspirate a little bit of blood instead of asking for a chest X-ray in case of problems.
Mm-hmm. I think that you should aspirate blood only if there is a serious suspicion of malfunction. If you say that you should aspirate blood anytime, anywhere, for any infusion, before an infusion, that will shorten the catheter life, because you will have the catheter flush with blood unnecessarily many times. The only reason, very good reason for ensuring that there is a blood reflux is before infusion of vesicant drugs, and that's a must. I would also add that there is not only X-ray. For instance, we often detect the presence of a very good flow inside the vessel, that the catheter is still inside the vessel by ultrasound. We flush the PICC or the port, even if this persists with occlusion, with any kind of wireless or not wireless convex probe. We check the coming of the flow, the so-called the bubble effect, the bubble sign in the right atrium, and you are perfectly sure if this happens within 1 second that the catheter is in the vessel and is very, very, very close to the atrium. This is something that could be very easily done at home, because at home it's impossible to have an X-ray, but you can have a wireless probe at home as we use it and check that the catheter is still inside the vessel. This is something quite new, but I think it will be developed in the future.
And also a matter of education.
Yes.
Yes, of course, you have to train people, but I tell you that we do training course about this, and it's very easy to detect this bubble sign.
Right.
It is not easy to see the catheter with the convex probe in an echocardio. You need to be a cardiologist, but it's very easy to see the right atrium and then with a flash see the bubble sign.
I just want to make one remark about the vesicating products. Some of the antibiotics given at home are also irritating for the vessel, not only chemotherapy drugs.
Yes. Definitely, but still, the vesicant drugs are the one. You know, the extravasation is a much higher risk of the infiltration. But you're perfectly right.
Yeah, and maybe Marguerite, there is a question here. I'll show it. It says, when urokinase, when alteplase. You know, I have an opinion, but maybe you or Christian do have an answer to that.
Christian first. He's the.
You first.
No. Okay. In our practice, we saw that alteplase is more expensive than urokinase, and the volume is smaller. When we try to disobstruct a catheter with this urokinase, we see that it's often useful to prolong a little bit the injection, and not only when shot of very concentrated product, but try to eliminate also the other clots a bit further in the bloodstream. And it's too expensive with the alteplase. And in former studies, I'm not sure that it was more effective.
Well, I think there's a problem of cost. She's right. Margaret is right, as usual. It was also a problem of availability of the right vial, because in England and USA and many other countries, they have the 2 milligram, 2 ml vials of urokinase, which are still expensive. But for instance, in Italy, we only have the 50 milligrams vials, which are incredibly expensive. And it's difficult to think of using such an expensive vial of 550 milligrams. So this is also an availability of products, which may differ from country to country. Urokinase is quite well spread, I think, in all European countries, but also because of this, because we don't have the small dose alteplase.
Right. And you know, if I can add, because you know, many of the questions are on DVT and prevention and how to treat. But Christian, in your presentation, I saw something about the 10 ml syringe, which was not quite clear to me, because you can use a smaller syringe if you have a power injectable catheter. Can you comment on that?
Yes, in France, we can do that. In French guidelines, we can use 10 milliliters syringe or more, but not less, because it's not in our habits, and we are afraid of interpretations. If you have silicone catheter and you inject with 2 milliliters syringe, you can break it. Of course, most of yours we say you don't have to use silicone catheter, but it's very difficult to know what kind of catheter is inserted. because traceability is not constant.
Well, it's not possible for the not expert, let's say. But if you have a vascular access expert, he knows perfectly well whether the catheter is power injectable or not power injectable. Anyway, I think this is a very good point. You should never use anything, any syringe less than 10 ml for any catheter. But we still think, and the GloVANet recommendations say that, and I think there is a very good evidence, sooner or later we will publish this evidence, that using a 2 ml syringe, which makes approximately 200, 180, 200 PSI, is still safe if you use a power injectable catheter, which usually is set to 300 or more PSI. And I think that this is a very simple maneuver. Of course, it depends. It cannot be generalized. For instance, in my hospital, it can be generalized because in my hospital, all PICs are always power injectable. We don't use silicon PICs. We don't use non-power PICs. But still, you must be careful because, as Christian pointed out, there are some people who may try to do this with a fragile catheter, and that would be an error. So let's see what happens in the future. I really hope that in the future, silicon will disappear. Silicon is terrible. So it must always be only polyurethane and power injectable polyurethane.
And what about high concentration alcohol to rinse a polyurethane catheter?
Well, there is no study showing that high concentration alcohol has any damage to new generation of polyurethane. There is a very big study, experimental study from the Mackey group, which shows that even the normal polyurethane, the old generation polyurethane, is not affected. There are other studies in the literature. I think there is at least 3 studies, 2 of them from Pisa, from the Technological Institute of Pisa, showing that the new generation polyurethane, which are Tecoplane, Tecoflex, Carbotan, Pelletan, etc., Chronoflex, are all resistant to high co-solution ethanol. Still, I will not use ethanol for other reason. As Christian said in one of his slides, ethanol unfortunately causes protein precipitation. So if you have a very good anti-effective effect, because it has it, and also if you can clear the lipids, still you will have the problem of protein precipitation. That was the message of your slide.
Right. Because of time, I have to ask Marguerite, is there any last comment you want to give? Because we switched to the second part of the session.
Maybe a small anecdote about the syringes. 2 milliliter syringes is maybe okay for polyurethane catheter if they are power injectable. But we had incidentally a survey in our hospital years ago, and the use was to flush catheters after blood administration or parenteral nutrition with a higher volume than 10 milliliter. And we saw that using a 20 milliliter syringe was less effective than twice a 10 milliliter syringe.
Okay, because of the turbulation.
It was not randomized, but it's just an observation, and we shift.
It makes sense because
based on the evidence.
The pressure of a 10 ml syringe is no more than 50 psi. On the contrary, the pressure of the 20 ml syringe is half of that. So obviously, you make less pressure. That makes sense.
Okay. Thank you very much, Marguerite. We have a short switch to Sergio, and Mauro will lead that discussion. But before we continue with the next speaker, thank you to Christian. I know that you are leaving, but thank you very much.
Sorry, Sergio.
Yes. And I want to point out again the importance of our and your relationship with our sponsors. For the availability of materials and innovative products we were just discussing, we are relying on the industry partners. If you have any questions or ideas for improving your practice, feel free to contact our sponsoring partners. And for the next part, Mauro, I hand it over to you. I introduced you already, but for you to introduce Sergio.
So no break?
Well, this was the break, but
this was a break.
yeah, it's really very short, thanking the sponsors, but just by showing the logo.
Yeah, maybe we can add as part of the break that we will do our best to answer all the questions that we have been not answering live on the website, right. Correct?
Right. Okay. That's correct. And some of the questions are more on DVT, but I'm looking at the questions. But for sure, you know, those questions that are still open will be sent to all the experts and the hosts to give answers.
Yeah, so please, everybody, visit the WoCoVA, the GloVANet website for looking for this discussion, these questions answered in the next future.
Yes, and also these recordings, that was a question too, will be available on the GloVANet website afterwards. Okay, Mauro.
Okay. Sorry, I must go. I should go. Thanks a lot.
Bye. Yes,
Christian. Thank you.
Bye, Christian.
Thank you. So the second part of our broadcast is about thrombosis. And it's a pleasure for me to introduce Sergio. I know Sergio since more than 20 years. He's one of the most important experts in vascular access in Italy and in Europe. He's a surgeon. He's an oncology surgeon. And in the last 20 years, like Margaret, she's a surgeon too, an oncology surgeon. And in the last 20 years, Sergio has published an incredible number of very good papers about PIC, about thrombosis, about PIC parts recently, and about the complication and management of short cannulas, and mostly about the comparison between saline and heparin, use of prefilled syringe, and many other very important topics. In particular, he is an expert of catheter-related thrombosis, as you will have noticed from many conferences and many interventions. So he will also be talking about this in the next WoCoVA in Athens. Please remember that we are trying to get in this learn from the expert sessions the best of the people who will be talking in the next Athens conference. So this is also wants to be a prelude to that. Sergio will be there, and hopefully all of us will be there if nothing bad happens in the world. And Sergio will be talking about the topic that will be addressed today, which is the prevention and management of catheter-related thrombosis. Sergio,
okay,
the public is yours. The audience is yours.
Okay, thank you very much, Mauro, for this nice introduction. And I hope to be on time. I will speak about how to prevent and treat catheter thrombosis. Well, first thing, those are my disclosures. And let's speak about the prevention of catheter thrombosis. Well, there are some aspects that we have to consider. We need a right catheter for a right patient. Not every catheter is ideal for every patient. We can have peripheral or central catheters, external or totally implantable catheters. We can have many materials, and we have to decide exactly the right catheter for the right patient. And that's the reason, because the producers produce so many types of catheters. We need a right assessment of the venous side we are going to place the catheter and the size of the vein itself. For peripherally inserted central catheters, midline or similar, we know that we should have an ideal respect of a catheter to vein ratio that should be inferior to 1/3. For ENS is 0.45, but we really, for Gaveseld and in Gaveseld in Italy and many other countries, we are more restrictive and we prefer 1/3. And finally, last but most important, we need a right technique of implant and management. Of course, we have to use percutaneous US implant technology and US It's probably the key that has changed a lot the story in the last 20 years. We'll go through that ahead. We have to use an appropriate microsildinger injection and an aseptic no-touch technique. And we need an appropriate location. And of course, very important, we need good management protocols. If we don't have that, we are going to be in trouble. Okay? That's not going ahead. It's happening. Risk factors. We have to consider several risk factors. There are factors that are patient factors. Mainly a previous history of DVT. It's a challenging situation. We do have to know the patient with a previous history of DVT is a high-risk patient. Cancer patients are important to consider, and especially the stage of cancer. It's very different to speak about the risk of thrombosis in an adjuvant treatment or on a palliative treatment of a metastatic patient. There are acquired factors. Every one of you knows Caprini, risk scores, or similar, Corana, or another that we have to consider. And there are congenital factors that very often we do not consider unless on specific population, like in oncology, in some areas of oncology, because the screening of congenital factors is expensive and cannot be used for all patients. There are factors related to materials. As Mauro was saying, today we have mainly third generation polyurethane catheters or silicone catheter. All around the world, we're moving more and more to use extensively polyurethane catheters more than silicone catheters. And finally, for external catheter, there are important factors related to the fixation and the stabilization methods that are very important on reducing or increasing the ratio, the incidence of catheter-related thrombosis. And finally, let me talk about the implanting technique. We need an extensive use of ultrasound. By ultrasound, we can have a good venous access site evaluation. We can have a reduction of the number of tentatives with less parietal damage, avoiding the double pass on the vascular wall. And we can choose and we can look always to the size of the vein and trying to respect the catheter to vein ratio I explained before. The extensive use of ultrasound is today probably the main factor that has reduced the incidence of catheter thrombosis in the latest 20 years. Let me speak about facts and figures about catheter-related thrombosis, because we have to know very well the problem we're facing. First of all, let me tell you that the incidence, it's moderate, and the rates, depending on the type of the catheter and patient medical history, and it's a very wide range. We have to consider also that over-thrombosis are less than 1/3 of the all thrombosis. We are not doing always screening for asymptomatic thrombosis, but in those papers where screening for asymptomatic thrombosis is done, you will see that the incidence of symptomatic thrombosis is less than 1/3 of the global. We have a very low mortality rate. We don't have to have fear about the mortality for thrombosis. The estimated fatal events attributable to a catheter-related venous thrombosis, it's very low, and rates are less than one every 5,000 thrombotic events. And finally, we have to consider that there is an elevated clinical impact of these complications because it requires medical treatment and monitoring, and this is expensive. And there is a patient fear, especially for pulmonary embolism and possible related mortality. And of course, this leads to an increase of economical resources. And those are the major facts and figures that we have to consider when speaking about catheter-related venous thrombosis. Which are the objectives of the treatment? Well, of course, reduce symptoms, prevent the extension of the thrombus, the progression of the thrombus, prevent the venous chronic occlusion, and prevent the recurrence of a thrombotic event and in pulmonary embolism. And an important objective is to maintain the catheter unless no longer needed, non-functional, dislodged, or infected. A catheter with a venous thrombosis has to be maintained if it's necessary, unless there is no functional dislodgement or functional impaired function or is infected. Why? Because even if the catheter is removed, anticoagulation is still required to prevent recurrent venous thrombosis for at least 3 months. We will go ahead on that. And probably we will need a reinsertion of a new catheter with new risk in other areas where we are going to reinsert the new catheter of a new thrombosis. And there is no evidence that the removal of the catheter improves the outcome. And this has been very well assessed by all the guidelines, especially AC, American Chest College of Physicians guidelines and recommendation. Then the idea, oh God, we have a thrombosis, let's remove the catheter that's going to solve the problem. That's not true. We are not to solve the problem, and we are not to have a better outcome by removing the catheter. Which is the therapeutic landscape is very similar to that of normal venous thrombosis, and is mainly based on anticoagulation that can be obtained by unfractionated heparin only today for patients with severe renal failure, mainly by low-weight molecular heparin on fundaparinux. We can obtain it also by vitamin K antagonists. We can obtain it also by direct oral anticoagulants, and we can obtain it by thrombolysis. We have a wide panel of possibilities to treat catheter-related venous thrombosis. We have to consider that there are 2 phases. The initial phase, when the patient is symptomatic, that lasts more or less around 3 months. And there is an extended phase of prolonged treatment that can go ahead for all the life of the catheter or for all the life of the patient, even if today there are many concerns about the extension of this second phase. Let's speak about the treatment, go inside the treatment. For non-cancer patient and for cancer patient, symptomatic or incidental asymptomatic thrombosis, the approach is at all similar. It's in initial phase from 5 to 10 days until 3 months is mainly based on anticoagulation with low molecular weight heparin or fundaparinux at therapeutic dosages. And this is what is recommended by the major guideline, and is the standard of practice of all of us today. But there is not a unique thing that we can do. The question is, can we use thrombolysis? Is there a role for thrombolysis? Probably yes, but it's a marginal role only for patients with superior vena cava syndrome or acute limb threat risking the compartmental syndrome or the loss of the limb, and for the severe symptoms progression in acute patients. In those cases, we can consider the use of recombinant TPA or urokinase for low bleed risk patients. For high risk bleed patients, we cannot use recombinant TPA or urokinase unless the risk of running on severe complications. And then after, when we have obtained our result, to continue anticoagulation. The drugs we can use or the commercial drugs available are several. Here you have a list of the major one. What's interesting is that today, all the producers, even of Enoxa or Dalte or Nadro, they tell you that you can, in many cases, use once a day administration, that you don't need administration every 12 hours. And this is especially true for fundaparinux, that is probably the most effective of all of them, even if in some manners probably more risky. What about the extended phase of the treatment? Well, for non-cancer patients, the extension to more than 3 months, it's only demanded for elevated risk patients. Generally, for non-cancer patients that become asymptomatic with the resolution of the symptoms, the treatment is stopped after 3 months. Well, if we need extended phase, we know that we can use the oral anticoagulations with antagonists of vitamin K that are maybe superior to low-weight molecular heparin for these extended treatments. And we know also from ACCP guidelines that the direct oral anticoagulations are today superior to vitamin K antagonists. The grade of the strength of those recommendations is not very high, but this is what ACCP suggests. For cancer patients, the situation is different because all the guidelines today still maintaining the assumption to continue indefinite anticoagulation as long the central venous catheter is in place and patients are under active treatment and chemotherapy. And here we can use low-weight molecular heparin or fundaparinux. We can even overlap to VQA antagonists with an INR target from 2 to 3 can be considered, and this can be considered for non-advanced or metastatic patients and not active chemotherapy, because as everyone knows, oral anticoagulations with vitamin K antagonists, it's very unsafe when chemotherapy is ongoing and for patients with maybe progression on the liver or impaired liver function, and it's very difficult to maintain target range stable. There are few data for cancer patients on extended treatment with direct oral anticoagulation for cancer patients. Well, in synthesis, for cancer patients in general, for extended treatment, the overlapping from low-weight molecular heparin to oral VQA antagonists is feasible and safe. It does not increase the risk of major bleeding, but considering a slight lower risk of recurrent VTE and the need for repeat INR monitoring, there is a favor, those factors favors the use of low-weight molecular heparin, even for extended treatment, even if patient has to be aware that he needs an subcutaneous injection daily, maybe for a very long, prolonged period of time. The use of antagonists of VQA is not indicated for cancer patients, as I told you before, with advanced or metastatic disease and active chemotherapy. What do we know about those group of new drugs, very, very interesting drugs that they are direct oral anticoagulation for extended therapy? Well, until a few years ago, we knew the presence of those drugs, but they were not checked in controlled trials. And on the last 2 years, there has been 2 very important trials. The first one is the GloVANet-WoCoVA trial, in which edoxaban was used as competitor to DALTE. And what we know that the incidence of recurrent VTE, venous thromboembolism, is slightly superior with DALTE, with a low significativity, but superior. But we know that means that the direct oral anticoagulation are more effective on preventing recurrent VTE, but we have to be aware that we can have a higher risk of major bleeding. And this has been observed especially in patients with gastrointestinal tract cancer. And those are the results of the GloVANet-WoCoVA trial, published in New England, very interesting. And this is a very similar trial with very similar result, is the SELECT trial by the group of N. Young. And you see again, The competitor in that case was not edoxaban, but was rivaroxaban. And Dalte has an effect somehow worse than rivaroxaban in preventing recurrent VTA, but Dalte was against low-weight molecular heparin was maybe safer on respect of the major bleeding. But if we go through the overall survival at 6 months, we can see that there is not attributable mortality, a major attributable mortality to the use of rivaroxaban. As you can see, both studies have shown very similar results in terms of good efficacy of the direct oral anticoagulation with somehow major risk of bleeding. And this is the summary of what we have today. Yes, we can use direct oral anticoagulation for extended treatment. We have to balance safety and efficacy and patient compliance that are very good, but we have also to take into the due account superior cost for extended treatment. And in that sense, we don't have specific trials for catheter-related thrombosis. All the trials that we have and that I have shown you are for cancer patients, but for all type of thrombosis, but not specifically for catheter venous thrombosis. And this is one missing of our knowledge that we will face on the next years. I hope is going to be faced by researchers on the next years. And I think we are going to have very interesting future results. But the true question that today is coming out more and more with a more and more attention from the part of people interested in central catheter is, do we really need extended treatment in case of catheter-related thrombosis? And this is an open controversy. The finality, of course, is to reduce persistent or recurrence and to prevent pulmonary embolism and related mortality. But let me show some data on that. There is only a very nice paper published in 2015 about the risk of recurrent deep venous thrombosis in patients with catheter-related thrombosis. This is a selective study on catheter-related thrombosis. And you see that the risk of global recurrence is around 2.5%, and the risk of recurrent pulmonary embolism is less than 2%, and the mortality for recurrence of pulmonary embolism is less than 1%. That means that the estimated global risk of mortality for catheter venous thrombosis is equal or less than 1 every 5,000 thrombotic events. Very, very low. Then the idea of paying so much attention to pharmacological control and treatment, extended pharmacological control and treatment, it's today very uncertain. As a matter of fact, a group of colleagues, Florence, published a very interesting and provoking paper last year in which they suggested the possibility that catheter-related thrombosis represents an unavoidable event following vessel wall trauma and occurs within 2 weeks from the venous catheter insertion. I disagree fully with this statement because this is true maybe in acute patient, but we know that in chronic, in oncological patient or in chronic situation, this thrombosis can occur even after 6 months or 1 year of a catheter in place. And it's not mandatory that this occur within 2 months. But they suggest also that for a symptomatic peak and sick related thrombosis, to do not treat them with not anticoagulation due to the low risk for patient pulmonary embolism and patient mortality. And for symptomatic peak and sick and central inserted central catheter related thrombosis requires prompt treatment and is not associated with significant risk of sequelae in not high-risk patients. I fully agree with them on that. This position was mainly based on pediatric study, and they are calling researchers to go ahead on this line to do more research on that. This is why this paper seems to be a little bit provocative, but it's very interesting on its on his rationale and on what we should do probably on the next years. The position based on evidence-based medicine and guidelines today is that extended thrombosis can be necessary for the persistence of symptoms, can be necessary for cancer patients in active treatment. And in those cases, the idea today is still stay on extended anticoagulation. But for no cancer patient in active treatment and in absence of risk factors and in clinical resolution of the thrombus and symptoms, probably after 3 months treatment, if you have the resolution of symptoms and the thrombus, you can stop extended anticoagulation. For other clinical scenarios, we need further trials. We don't have today other answers to give or other suggestions, rational suggestions to give to the audience apart of that. Let me tell you finally a special scenario that very often is required when to remove a catheter. If you decide that is indicated to remove a catheter after a thrombosis, well, remember that you need at least from 3 to 10 days of previous anticoagulation to remove the catheter and to extend anticoagulation for at least 3 months. I thank you very much for your attention, and I'm here. I will try to answer to the questions.
Thank you very much, Sergio. We have only 15 minutes for questions. So thank you for this very good presentation, which as usually from you is a mix of deep knowledge of the literature and solid, good common sense. Because many of these problems with thrombosis is due to the fact that people, clinicians, when they see a thrombosis, they lose their common good sense and they are terrorized, and they very often use very expensive diagnostic tools or very expensive or prolonged treatment, and often they do things which are not appropriate for the patient. Do we have questions? While Tom talks, can you comment on one problem which is very close to my concern, which is the fact that very often in an oncological patient, there is an incidental diagnosis of thrombosis, which is not asymptomatic thrombosis, which as a matter of fact is not asymptomatic thrombosis, but is a fibroblastic sleeve, is the catheter sleeve. Do you think is this a concern for you too? Because I see it every day in my practice.
The question is for me or for Tom?
Yes,
no, for you.
Tom,
okay.
Tom is
I fully agree with you in the sense that very often in oncology, due to the fact that we do a lot of CT scans or checks of the patients because they are on clinical trials, and we repeat expensive diagnostic procedure to have an idea of the response, we see what is named an incidental thrombosis. But very often, if you go through the radiologist, it's not maybe a complete thrombosis, and it's a fibroblastic reaction, as you say. To define a thrombosis, we have to have other signs that very often are not present. But this is something that has to come into the mentality of the radiologist. Because the medical oncologist, in the moment that he says a referee with a written thrombosis, he immediately says, okay, I have a thrombosis, I have to pay attention to that, I have to treat the patient. And very often it's not that, especially for peripheral catheters.
This accounts for a number of useless for PICs in the middle. This is account for a number of useless anticoagulation treatments.
I agree. I fully agree with you. We have to pay attention because anticoagulation anyway has risks and mortality also.
Mm-hmm. Tom.
Yeah, I think one interesting question comes up here from M. That's not Mauro. It says, how do you investigate? Well, how do you investigate if a catheter-related thrombosis is infected? Or do you assume that every present thrombosis in case of a line sepsis will be infected? I think that's a good question.
No, not every thrombosis or line thrombosis is infected, fortunately. No. Fortunately, not. To accept that an infection is due to a thrombosis, you have to exclude other reasons. You have to look at, for external catheter, to symptomatic or clear objective or evident infection. And you have many helps from the lab in terms of cultures, in terms of procalcitonin, in terms of other markers like PCR and so on. But you need a demonstration, of course. It's preferably if you have a demonstration of a positive blood culture, systemic, or from also or even from the catheter. But not all the thrombosis, fortunately, are septic thrombosis. Very few of them.
Yeah, very few. There is an urban legend, which is not substantiated by any evidence, which says that thrombosis causes infection, infection causes thrombosis.
This is an old story.
I don't believe it's an old story. There is a very nice paper we published on JVA recently about 254 pigs in which there was not one infection. There was 25% evidence at ultrasound of fibroblastic sleeve, 5% asymptomatic thrombosis, and 0.5% of thrombosis, and no infection. This gives an idea of the numbers when you do a prospective trial. Infection is lethal, it's terrible, but infection and thrombosis together is more the exception than the rule.
Exactly.
Yeah, I think that this is very important to clear, because this is very much discussed in our practice. I have here, what would you suggest to keep the catheter in situ even if it is a midline with confirmed thrombosis? No.
Maybe Margaret wants?
Yes.
Okay.
Okay.
Another question.
I mean, of course, a midline usually gets a thrombosis because of the infusate, which gives a thrombosis at the tip, which is a malfunctioning catheter anyway. So a midline should be removed because most of the time is a thrombosis at the tip. Sergio did not have the time to go through all the aspects of pathogenesis of thrombosis, but what we see typically is the thrombosis at the point of insertion, where there is the damage of the wall.
Exactly.
And the thrombosis at the tip, where there is a chemical damage to the wall or even mechanical damage.
The elevated risk of failure of midlines and the elevated risk of thrombosis is probably due to what Mauro has said. It's a bad use of those catheters that are perfused with wrong solutions that shouldn't be used for midlines. And very often on the external side, there is not a clear differentiation between a PICC, a PIC, or a midline, and very often there is confusion, and they are bad used and used as a central catheter, and they are not central catheters.
Yes, and maybe the other question that I have here from a person, Renee, is location of the PIC tip important in prevention occlusion of the PIC line? And that's probably answered by your last comment.
Yes, it is. We can discuss a lot about 1 centimeter closer or not closer, but of course, the presence of a catheter on the lower third of the inferior vena cava, it's fundamental and mandatory for any type of central catheters.
Superior vena cava.
Superior, not inferior. Sorry. In the lower third of the superior vena cava, it's mandatory to have a good functioning of a catheter. Yeah. We don't need to go back to the Peterson study of the last century to know that. Today we know very well that we can discuss 1 centimeter more or less, do the difference, but this is theoretically or very choosy if you want. But the important thing is that the catheter is located in the inferior third of the superior vena cava, as close as possible to the right lateral junction.
But the clinical practice
and
has shown
today we
also
have the methods, or a good echography or an ACG method.
But the clinical practice has shown that also if the catheter is somehow at the entrance of the atrium, the upper part of the atrium, it does not make difference.
Exactly.
The real risk of thrombosis, I don't know if you agree, Sergio, is not because it's higher in the middle third of superior vena cava, but because that position is associated with the possibility of a catheter stuck to the wall of the superior vena cava, which is the chemical damage and the mechanical damage. So,
exactly. When the catheter is short, as Christian Dupont showed before on his slides, it moves very easily, and it can be very easily go stuck to the wall, and can be what is called horizontalization of the catheter if you come from the left side or the right side, both are together. And in that case, the turbulence is higher, and this is why probably we have more. And this is especially true for patients doing parenteral nutrition with high osmolarity solution, infusion of high osmolarity solution. It's probably somehow less important for cancer patients, but for patients doing parenteral nutrition, this is fundamental too, to have the right deposition of the catheter.
With only a few minutes left for our discussion, I want to stress again that all questions will be sent to the experts to answer. But I think this one is interesting, and I'll show it. What can we do in patients who thrombosis is confirmed and is allergic for treatment? Is there any alternative in medication? Or what can you do if the patient seems to be allergic for the
allergic
treatment?
to what?
Well, here it says enoxaparin. Enoxaparin. Yeah, sorry, I pronounced it not so good.
I can answer you to that because we have faced that problem. There is a constant increase of nodes of allergy to enoxaparin. I don't know if this is due to other compounds inside the solution or excipients inside the solution or not. You can shift very easily to another low-weight molecular heparin, or you can shift very easily to fundaparinox. That very often it's a five peptide molecule that has very, very low rates of allergy.
Okay, so there are alternatives. There are quite a lot of questions still about silicone and polyurethane. I think the answer was there already, that nowadays the new materials in polyurethane are preventable because of high pressure injection. That is the option.
I have a personal very strong conviction on that. I think that there is no difference on the risk of thrombosis between silicone and polyurethane. Nevertheless, there is a higher risk of mechanical complication from silicone, from dislodgement from silicone, ruptures from silicone, and so on. And that's why, and more difficult techniques of insertion for smaller catheters. And that's why I fully agree with Mauro, all the catheters in the future will probably be on polyurethane. Even if the biocompatibility of silicone is very good, there are many features that favors the use of polyurethane, but it has never been demonstrated on randomized clinical trials of a higher risk of thrombosis between using as competitors silicone and polyurethane. They have the similar rates.
But okay, but maybe the last comment, that's from Christel Janssens, from a colleague from Marguerite. And that is about the administration of ethanol. Again, it was mentioned before, but they saw leakage in polyurethane and other materials, catheters, but particularly in the hub, in the connections. And I think personally that connections for high pressure injection or of utmost importance to prevent leakage and other problems.
I have no personal experience on that. I think Mauro has more experience than me on that, and he probably can answer in a better manner.
Well, we stopped using ethanol. The reason for using ethanol may be two. Either you use ethanol because you want to disobstruct a catheter stuck with the lipids, typically in parenteral nutrition, or because you want to make a prevention lock or a treatment lock with an anti-infective purpose. I think that in both situations, ethanol is not ideal anymore. In terms of this obstruction lipids or prevention obstruction by lipids, I think that the best thing is to do a prevention, is using a pump for delivery the lipids, because the lipids will accumulate only when there is no flushing and no flow with the pump. But the flushing that Christian has described is enough also for prevention of obstruction due to lipids. If you flush with saline, with 2 ml, with 2 syringe, 10 ml syringe of flushing, 10 ml in 20 ml total, every day, when you change the nutritional bag, then you will actively and effectively prevent. As regard infection, I think that ethanol is very strong as an effective, but it has a lot of problems. The problems of damage to the material is only part of the story. The other part of the story is that if you use it in a delicate people, like in pediatric and neonatal patient, the small amount of ethanol which goes into the circulation might have some neurological damage that's been described.
Exactly.
And also the fact that ethanol might spark the precipitation of protein, so to use an occlusion. So as a way of preventing infection or treating infection with a lock, I think that the other substances we have mentioned before, such as taurolidine or high concentration citrate, or maybe there are some first data about it, the ADTA, I think they are more appropriate and more cost effective than ethanol.
Mm-hmm. Okay, also due to time, and thank you for, let's say, last comments from you, Mauro. I have to come to a closure because we are running a little bit out of time. But I think it shows that there's a lot of need for information, for discussion, and that we should continue this type of sessions, as we will do. But before closing this first Meet the Expert session, I want to thank you all, the expert speakers, and of course the hosts that were very active in the discussion as well, for all your valuable contributions. And of course, we have to look at the evidence and clinical outcomes, but we need to share thoughts and practice results. I hope that this Meet the Expert session will add a step in improving vascular access care for all patients worldwide. That's our goal. I also want to thank Live Events Online for hosting the technique and smooth streaming of this event. I think it runs smoothly. Also a special thank to Jacqueline Zilventand and Twan Hulshoff for structuring and preparing this Meet the Expert session. And I also want to thank the sponsors again, and hopefully we will have a few more next time. But last but not least, I want to mention the next Meet the Expert session on November 24th, same time. And for some, it will be late or even in the middle of the night. But all these sessions will be available on the GloVANet website shortly after the session has been live. But of course, you cannot ask the questions anymore, but you are maybe able to contact the expert speakers personally by sending an email. But all the questions will be sent to the experts and will be answered later on.
Good. And the topics of next appointment.
Yeah, they're shown. So you should mark your agenda. Free registration will be open very soon, but we will also inform you by email. You know, with the Meet the Expert sessions, we give you a glimpse of a full program that will be offered to you in Athens, 7th to the 9th of April in Athens in Greece, where we hope to meet you all. And, you know, the program for the next time is in a slide, Mauro. Thank you again, particularly you, for attending, also to the people at home or at work, or as you could see that some people are just breaking out of their work area. but thank you for attending, and we look forward to see you again in the second session on the 24th of November. Thank you all.
Thank you, Don.